topic that I've been asked to touch base on are the effects of cancer treatment on cardiovascular health broadly. And I've been in this clinical as well as research space for a number of years now, and we have a very vibrant cardio-oncology program here, and trying to expand it to some of the Northwestern ancillary sites as well. So cancer survivorship is increasing in the United States, and we're expecting, I'll just give the answer to this first question. We're expecting over 20 million survivors by 2026. I think the global population is increasing, but cancer survivorship is increasing. And that's why this sort of niche within cardiology has now become so important. So cardio-oncology, it really is just a bridging field that is growing alongside cancer treatment and survivorship. So cancer therapies are just expanding and really becoming better and better. Alongside that, with survivorship, and then patients are dealing with long-term issues. And so cardiotoxicity can be really the primary determinant of the quality of life. The cardiovascular disease is the second leading cause of cancer, of mortality in cancer patients. And we'll touch a little bit about types of patients we're seeing here in the Bluhm Cardiovascular Institute's Cardio-Oncology Clinic. But it accounts for about 21% of mortality in our breast cancer population. And I really started in this space because I felt that our patients needed a better advocate, because the diagnosis of cancer often really scares cardiologists, who may undertreat patients due to concerns about their prognosis. And the diagnosis of heart disease scares the oncologists, who may undertreat patients due to concerns for cardiotoxicity. So there really need to be someone, or a person with kind of an understanding of both therapies and cardiovascular disease to reassure both patient and provider that moving forward with the planned therapy is something that that we can partner with. And so these are just the 5-year survival rates to kind of the most recent time period. And as you can see, cancer survivorship is increasing across all cancer subtypes. And I put an asterisk next to the treatment, the cancer subtypes that receive a specific type of cancer therapy called anthracycline agents. And this type of drug has been around for many decades. So breast leukemia and lymphoma are frequently patients that we see in our cardio-oncology clinics because they've received anthracyclines, and anthracyclines can affect the heart function. Here, I'd like to show a slide specific to breast cancer and show that this was a population-based study of over 100,000 patients with early-stage non-metastatic breast cancer. And so what we see here is that age matters, and that as if you're older patient, like older than 65, you can see that on the panel B, that the red line represents cardiovascular disease and the yellow line represents breast cancer, so that cardiovascular death has become the leading cause of death after the age of 65. We also know that if you carry a pre-existing cardiovascular disease before your cancer diagnosis, that's also something that places you at higher risk for cardiovascular disease. And again, if you focus on panel B, you see that patients who survive their breast cancer diagnosis by greater than 5 years, cardiovascular mortality then becomes number one, and it exceeds breast cancer mortality after a certain time period into survivorship. And so women with breast cancer who survive longer are more likely to die of cardiovascular disease. So what is the history of cardio-oncology practices? It really goes back about 15 years or so. They started in cancer specialty hospitals like MD Anderson, Memorial Sloan Kettering, where cardiologists were employed to take care of the patients at these hospitals. But now you really will find a cardio-oncologist at most academic institutions, and even now in community hospital settings. And this is becoming more prevalent again because of the types of treatment patients are receiving. And I'd like to kind of point to trastuzumab, which is a anti-HER2 therapy that's given for our breast cancer population who have HER2 positive breast cancer. Now, the FDA indicates that frequent surveillance of these patients, because that is how the clinical trials were designed, where even an early stage breast cancer patient requires an echo every 3 months on treatment, according to our current protocols. So with that kind of detailed surveillance during treatment, you can really see that you need a cardiologist partner to help in managing patients. I'd like to also say that, cardio-oncology has become such an important area within cardiology that we have a subjournal within a major cardiology journal called the Journal of American College of Cardiology has a subjournal just for cardio-oncology now as of 2019. And so what are the goals of cardio-oncology? It really is to provide seamless care between cardiology and oncology services for cancer patients with cardiovascular issues. By improving our patient outcomes, we want to prevent or minimize the cessation of much needed cancer therapy. So we also would like to identify early and late effects from cancer treatment using some state-of-the-art imaging tools, newer blood tests that are coming along the way, and we hope that in this collaboration, there will be a better understanding of the mechanisms for toxicity. So when I sit down with a patient, I really try to reassure patients that I am a partner and that if the cancer treatment is needed, if it's being given for life-saving purposes, that the oncologic benefit outweighs the cardiovascular risk with close surveillance for cardiovascular risk and understanding and knowledge of the cardiovascular risk before treatment. So my goal is not to stop therapy, but rather to make sure that's given safely. And this is the cancer care continuum. We see patients primarily are referred to us right now when receiving treatment and having developed a cardiovascular side effect or during survivorship. But I would like to say that this is something that we'd like to move forward in the direction of prevention. So let's try to rethink our paradigm for how we take care of each other and consider our work in prevention and early detection of heart disease is ideally overlapping with cancer prevention as well. Next slide. Sorry, I'm forgetting to say next slide. This Venn diagram comes from a paper that looked at the overlap again between cardiovascular disease and breast cancer. And you can see that there are several risk factors that overlap between both entities. Next slide. Physical activity is really a crucial part of how one will fare during and after cancer treatment. And this is a nice study done by one of my colleagues over at Rush, Dr. Okuosa, that she looked at pre-breast cancer diagnosis, exercise, and cardiovascular outcomes in the Women's Health Initiative, and found that if you were exercising more before your cancer diagnosis, there was a higher likelihood of surviving without a cardiovascular effect after your treatment. This is a review paper that we've recently put together and is under review, but I'd like to share this slide with you because I feel very strongly about kind of thinking about prevention very broadly and thinking about prevention from social science perspective, policy perspective, and then how that then translate down to clinical medicine, clinical risk factors, and then even translates further down to basic science. And we can see that there is, a lot of overlap between breast cancer and heart failure on this slide, and that the social parameters that one lives in is an important it's important for us as clinicians to think about patients very broadly and what kind of limitations that patients have in coming to doctor appointments, getting their medications, the types of foods that are available to them. There's a lot of other things that we need to be taking into consideration when we think about that concept of prevention. One of the other things that I've liked to explain to patients is, try to reframe your thoughts on cardiovascular risk factors and think of them also as potential risk factors for cancer development. And again, this comes from the review that's under review. But several cardiovascular risk factors, such as obesity, diabetes, hyperlipidemia, hypertension, and even atrial fibrillation, increase the risk for breast cancer. So by treating your cholesterol, you're actually reducing your risk for breast cancer. And that's being shown in studies specifically looking at postmenopausal hormone-positive women. So I think this is a very exciting area, and to see the overlap, between these risk factors and how we can really tackle both disease processes is very exciting and interesting. Next slide. So the American Society of Clinical Oncology put forth a guideline statement on taking care of patients who are at risk for developing cardiac dysfunction, which is probably the most common cardiotoxicity that we see in cardio-oncology clinic. And they identified 3 major time points during this continuum in which patients were at risk for cardiotoxicity, specifically cardiac dysfunction. So they recognized that that prevention strategies were needed to minimize risk before initiation of treatment, also during treatment, and then what were the preferred surveillance and monitoring approaches after treatment. So these are some of the reasons that we see patients in our clinic. In terms of pre-treatment patients, we see about, I think around 20% of the patients referred to us are patients who have pre-existing cardiovascular disease or are thought to be at high risk for cardiovascular disease and going into treatment that can affect their heart. So we evaluate those patients and we try to devise some prevention strategies to minimize cardiotoxicity. During treatment, there are many reasons that we see patients who develop problems with their heart pumping function, also called left ventricular dysfunction. Now, patients can be symptomatic or asymptomatic. Chest pain is a common reason, blood pressure management, pericardial disease, so heart sits in a sac around the heart, and within that sac around the heart, there can be issues that come up during cancer therapy. Fluid may develop there, and that is called pericardial effusion. So that's another reason we see patients arrhythmias, heart rhythm problems that may develop either due to the treatment itself or just the other milieu of issues that our patients face. Pulmonary hypertension, which is elevated blood pressure in the lungs, and diseases of the vasculature, the aorta, which is a big blood vessel that takes blood from the heart. And post-treatment, the long-term cardiovascular risk assessment. This is primarily done by our survivorship clinics, but if they identify some issues in their risk assessment, then they'll refer patients to cardio-oncology clinic. We did an overview of about a year of patients in our clinic and found that the majority of patients that we were seeing were female. Most of these patients have been seen by another cardiologist already, either on the inpatient or outpatient setting, and then getting referred to see us. Like I said, about 20% are for pre-chemotherapy risk assessment. The majority of patients we're seeing are for reduced heart pumping function, either symptomatic or asymptomatic. Then the next largest group is arrhythmias, and then management of coronary artery disease. And very interestingly, over 80% of our patients have 2 or more cardiovascular risk factors. Also interesting to note, so not all heart failure that we see in our clinic is due to chemotherapy. There are other reasons for heart failure that, that we see and that have to be sorted out by the cardiologist. So this is a lot of what we just covered. The majority are female, the reasons for visit. 40% of our patients are breast cancer patients, and the next largest group are lymphoma patients, lung cancer, leukemias, and myeloma patients. So we see majority of our patients are have solid tumors, but we also see patients with hematologic malignancies as well. And just in terms of some of the medical procedural things that were done between the risk groups, so we divided patients up into the high and low risk groups based on that ASCO guideline statement, which identified risk factors for patients to go on to develop cardiac dysfunction. So some medication changes were made primarily in our clinic, beta blockers. But also interestingly, patients were referred more often in the lower risk group for stenting than the higher risk group, and we can contemplate the reasons for that. So we discussed a little bit already about the stages for evaluation, for risk stratification, early identification and detection of disease, prediction of recovery, and detection of injury in survivors, and the types of clinical syndromes that we're seeing, problems with the pumping function, the pericardium, the blood vessels that supply the heart, the coronaries, the pressures in the lungs, and then other blood vessels that are involved. And there's multiple imaging modalities in our armamentarium to evaluate this. So in terms of what are some of the prevention strategies that we can use before starting cancer therapy, first I'd like to step back and discuss what is the definition of cancer therapy related cardiac dysfunction. So again, it depends on the type of treatment that you're receiving, but the definition that we go by, it's probably the simplest definition. There's several definitions out there. This is put forth by the American Society of Echocardiography. But the baseline assessment of heart function is very important. And so that baseline ejection fraction before starting cancer treatment. Now, ejection fraction represents the number that is ejected from the heart every time the heart beats. And so when the heart ejects blood, our heart is a muscle and it ejects at a rate of about 55 to 60%. That's normal. So if your ejection fraction starts at 60% and it goes down to 50%, that's a 10% decline in the heart function. And if it goes down to a value less than 53% or less than lower limits of normal for whatever the lab defines as that, so around 50 to 53%, then you've met the criteria for what we consider a clinically significant change in the heart function. With that change in heart function, patients will then be referred to cardio-oncology clinic and will decide whether or not it's safe to continue therapy or if there needs to be a therapy holiday until heart function recovers. There are many limitations to ejection fraction, and so subtle changes in the heart function, and this is usually done by echocardiography, which is an ultrasound picture of the heart. It may be imprecise depending on patients. In our breast cancer patient population, in particular after surgery, mastectomy, radiation with expanders, it sometimes can become very difficult to see the heart and get a truly accurate assessment of ejection fraction. And so there are alternate imaging modalities you can use, like cardiac MRI, to make those assessments. There's also this new echo parameter that you may start to hear more about, or you may already know about, that your cardiologist and your oncologist may be following, and that's called STRAIN. So STRAIN is an automated software that we employ on echoes here at Northwestern. We've been doing STRAIN for several years now, and specifically in our cardio-oncology population, there has been data more specifically in breast cancer patients, HER2 positive, who are receiving these serial echoes. We have many time points to follow patients, that we can see a change in this strain number that can predate a change in the ejection fraction. And so again, it's a automated software. We're looking at speckle motion within the heart muscle and how those speckles move. And so the speckle motion, it can be a more sensitive measure of your heart mechanics and a more robust and reproducible measure. So we are tracking the strain alongside change in ejection fraction in our patients. So we think about who is at risk for cardiotoxicity. We've talked a little bit about traditional cardiovascular risk factors. So patients who carry more of those risk factors are at higher risk. And then the cancer subtypes, what the subtypes we're seeing in our population is really driven by the cancer therapy that patients are receiving. And this is, again, based on our ASCO guideline statement that said patients with high doses of this specific type of chemotherapy called anthracyclines, high doses of chest radiation, or combinations of low doses of these treatments. And then there are, sorry, that's not my next slide. My next slide is with regards to again, who's at risk for cardiotoxicity. The cardio-oncologist will take a look at either the treatment regimen that's planned or the patient is already ongoing. And there's some data looking at the probability of developing cardiotoxicity according to treatment regimens. But this has really been mostly worked out for our breast cancer population in patients who are receiving anthracyclines and anti-HER2 therapies. And this is something that we really need more information on with other treatments. But so when I think about who's at high risk, I think about patients who carry risk factors, who are receiving high doses of treatment. So either high doses or they have the two hit. So two hits, like two high dose treatments, or cardiovascular risk and high dose treatment. And those patients, we have a recommendation both by the American Society of Clinical Oncology as well as the European Society of Medical Oncology, ESMO, to get an echo within the first year post-treatment. And again, this is very specific to the cancer therapy that patients are receiving, whether or not that's recommended in terms of the follow-up. But there's no longer that, okay, your cancer treatment is done and you're on your way. We're paying a lot more attention to both patients before, during, and after treatment, and what kind of things that patients should be thinking about and know about as they move forward into the survivorship period. This slide is just to show that there are a lot of other treatments that are being developed in oncology that can affect the heart. And these are all treatments that can potentially affect the heart function. So we've talked about anthracyclines and anti-HER2 therapies, but the new kid on the block is immunotherapy, immune checkpoint inhibitors, CAR T-cell therapies. There's lots of new targeted therapies for many different cancer therapies that can also carry a risk for decrease in the heart function. So before starting treatment, we recommend a comprehensive risk factor screening, identifying patients who are at high risk, really trying to identify modifiable risk factors and baseline echo depending on cancer therapy, and to possibly avoid cardiotoxic therapy if that is indicated. Now, what do we do during treatment? And so for this, I have a case, and I hope that the images are moving. Because if they're not, then it will be.
They're moving.
Okay, good. It won't be as interesting. So this is a 55-year-old woman. She has hypertension, HER2 positive breast cancer. She's received a treatment regimen for her breast cancer that has both an anthracycline as well as an anti-HER2 treatment in there. So two treatments that can affect the heart function. And now she's finished with that part of her treatment and receiving only the anti-HER2 therapy. This is her baseline echo. And again, an ultrasound picture of her heart from two views. You have the short axis view on your left, and on the right, you have a kind of a long axis view. Both of these views are of the left ventricle, which is the main pump of the heart. And the baseline echo here is 60%. The other number is her strain. Normal, the strain number is represented as a negative percent. And I think the main thing to remember from today is that more negative indicates better contractility than less negative. But so both of these numbers are tracked. So baseline, everything looks good. Both her ejection fraction and her strain are in a normal range. And this is just showing that we review strain curves, and there's something here called a bullseye plot that we're looking at too. And now, remember, I said that these patients are receiving echoes at every 3-month interval. So now we have a 3-month surveillance echo, in which, by the difference between the first set of images and this one is that the first set of images, it looked like the picture was inverted, right? The blood pool was white and the myocardium, or the heart muscle, was dark. Here we have kind of the more traditional echo. That one was done with contrast. So contrast is also important and usually is decided on the day of the study whether or not a patient needs contrast to help delineate out the blood muscle border, or the endocardium, to make an assessment of the heart function. But here on her echo, she did not receive the contrast, and her ejection fraction is noted to be just a little bit lower, maybe a low normal range. The strain has also reduced a little bit. It went from -21 to -16, so it's a little less negative. And then on her 6-month echo, you really see, again, we're back to contrast images of the left ventricle. You really see a change. Perhaps you can appreciate this change in her heart function, where her ejection fraction has dropped by 20 points, from 60% now down to 40%. Next slide. And so on her 3-month echo, there was no significant change in ejection fraction, but there was this kind of, maybe this red flag that there was a decline in her strain. Per our current standard of care, we continue cancer therapy without really any modification or interruption. At 6 months, then we have a clinically significant change with an interruption that's necessary. When her ejection fraction is at 40%, that's kind of a yes, we need to hold treatment until we can get the heart better. So can we identify opportunities for earlier intervention that may allow for continuation of therapy? And I think that's an area of a lot of research right now with strain imaging, because it can predate changes in the ejection fraction. But during treatment, we see patients in clinic. We see patients who've already had a drop in ejection fraction, and we also see patients who come to us with just a change in the strain. So we use that change of strain as like a red flag, like, okay, let's think about what we can do at this moment that we could do better. Treat and screen for modifiable risk factors. We, depending again on the treatment, can discuss alternate treatment delivery strategies for very high-risk patients. We talk about how we're going to surveillance moving forward. And if a patient is receiving radiation, this is a whole talk in and of itself, which I'm sure that LivingWell can have in the future to discuss techniques to lower the dose of radiation to the heart. But this is our next slide is an echo-guided clinical decision-making strategy. And again, if the heart function is normal by ejection fraction, everything is, great. We continue therapy without stopping. When the heart function declines to less than 40%, that is time to, really hit the pause button, initiate some therapies that can help improve the heart function and strength, discuss with oncology if there's any alternate treatments. If not, wait till the heart function improves before resuming or re-challenging treatment. And again, that strain number can be used for ejection fractions anywhere really between 40 to 50% range to help us in assessing. It's a second objective measure of the heart function that can help us in terms of deciding whether we need to optimize risk factors, closer surveillance, just check in with the patient, make sure there's no symptoms happening. And then research is ongoing whether or not we should be intervening with medications at this point. But so what are some of our mitigation strategies, really to kind of think about patients from the personal risk factors that they bring to the table to what are the potential prophylactic treatments we can give and our tools currently in cardiology. and what patient groups have shown some benefit for receiving those treatments. And then also to consider the oncologic therapy and any factors that we know that can help modify the risk. Maybe, and that's also a discussion again with your oncologist. So modifying dose, formulation, method of administration, again, depending on the cancer treatment. There have been some studies looking at all of these things. What is the role of cardio-oncology after completion of treatment? Well, risk, we are identifying patients who are at risk for developing cardiac dysfunction in the future, and hopefully also in prediction of recovery. So our next slide is a very important slide. It was a study that was done out of Italy about, it was a prospective study over the course of 8 years, where they included approximately 200 patients who had received this anthracycline type chemotherapy and had a drop in the heart function ejection fraction to less than 45%. And this was thought to be primarily due to chemotherapy. What we see here is that patients who were started on treatment for heart to improve heart function. So there's some specific therapies given in cardiology that you may be aware of, but beta blockers, ACE inhibitors, or some of the treatments that were used in this specific study. If the time to initiation of those treatments was before 6 months, you would see a response in the heart function. But if it was delayed, then there was less. In this study, nobody improved. And so it is important to detect changes early, to detect toxicities early, and to intervene when we can. And so because of that, both the ASCO as well as ESMO guideline statements suggest an echo within 6 to 12 months post-treatment in, again, patients who are at high risk for developing cardiotoxicity. Whether you're symptomatic or asymptomatic, if there's a change on that echo, it should be seen by a cardiologist. And this last slide is just a touch on radiation therapy. As you know, radiation exposure, chest radiation exposure, the higher the dose of radiation exposure places you at risk for cardiovascular issues. And radiation, really, the cardiovascular toxicities for radiations are more long-term. We tend not to see them during treatment, but we're talking about a few decades later. And so this is primarily for us right now more of a consideration in our childhood cancer survivors. But patients who have risk factors, are farther out from radiation treatment, have been given radiation with concomitant chemotherapy. These are the patient groups that are at higher risk for developing radiation-related cardiac toxicities. So in summary, for patients, I think that the pre-treatment cardiac risk assessment, I think that, we should start thinking about this kind of like pre-surgical assessment, pre-chemo assessment, and especially if you are at higher risk. Have that discussion with your oncologist. If there are cardiotoxicities that are anticipated with your treatment, then maybe start to partner with a cardiologist or cardio-oncologist before starting treatment and identify ways that you can hopefully mitigate or surveillance for those things. That we should even during cancer treatment, as much as possible, stay active. In fact, the American Heart Association and the American Cancer Society, both societies, recommend for our patients and survivors to obtain at least 150 minutes per week of a moderate intensity aerobic exercise. And so when I'm asked, like, what does that mean? Really that's individual for every patient. And I would say, 30 minutes, 5 days a week. And you don't have to get to that by tomorrow. I mean, that can be a goal for several weeks down the road. But, where you're getting to a point where by the end of exercise, you're a little breathless, you're a little sweaty. But to try to keep that up regularly, so the regular exercise is more important than doing it once a week for a long period of time and then being wiped out for the rest of the week. Blood pressure. we are seeing that patients who have uncontrolled blood pressure on treatment are more likely to get toxicities, cardiotoxicities, more likely to get the problems with the heart function. And so monitoring for blood pressure changes. There are specific treatments that are just known to elevate blood pressure within days to weeks. I'm thinking about bevacizumab, which is also Avastin. It's given very commonly colon cancer. That is known to cause hypertension, and that category of drugs known to cause hypertension in the majority of patients. So knowing, what you should be anticipating will help you and your doctors get through your treatment safely, and also commit to not giving yourself the excuse that, okay, I'm going through therapy now, I can just eat whatever I want, because at the end of treatment, it'll be hard to shift back to eating healthy, and try to make healthy choices even during treatment. So these are some things that we think about, pre-treatment, during treatment, developing that cancer treatment plan alongside your oncologist. And during treatment, we've talked a little bit about surveillance, imaging surveillance. There are also many other things that we can surveillance depending, again, on the treatment and whether or not it affects the electrical conduction system, whether or not there's specific blood tests that can help in determining if a patient's symptoms are related to the heart. But close surveillance also for blood pressure, for symptoms, is important to know what to watch for before going into treatment and be on the lookout for it so that you can identify it and report it to your physician, your oncologist, your cardiologist. Post-treatment, again, follow the surveillance plan that's developed by the survivorship clinic. I think Northwestern, we now have 4 different survivorship clinics, which is really cool. And so, that risk assessment for long-term cardiovascular effects, depending on treatment, is as important as anything. And this last slide, just I don't know if everyone has seen this in the news, but Max Perot, who I think snowboards for Canada, he was diagnosed with Hodgkin's lymphoma 3 years ago. So he participated in Winter Olympics 4 years ago. A year later, I think he won silver then. A year later was diagnosed with Hodgkin's lymphoma, went through 12 rounds of chemotherapy, and came back just this week to win gold. So it was an inspiring story. Thank you.